Greetings, everyone. Welcome to our webinar for today. Today will be heat emergencies, recognition, management, and operational considerations. If you have not done so already, could you please put your name and license number in the chat so we can ensure that you get credits for today. If you are from out of state and need a certificate, please send me an email, which I'll throw in the chat there for you, and we'll get that for you. So I'd like to introduce today Sarah Nelson. She is a emergency room physician here at Maine Medical Center. She's also an associate professor of emergency medicine at Tufts, and is our fellowship director for our educational fellowship. Sarah.
Great. Thanks, Eric, so much. It's great to be here. Matt sent me a text early on saying there's gonna be like 200 people on this team, so not to be nervous. So I'm not nervous, Matt, but I'm excited to be here. In addition, so I've been at Maine Med for over 17 years, which is crazy. And one of the cool side hustles I get to do is I run our wilderness medicine curriculum. And so one of the talks that we give is about heat emergencies. I also used to run our wilderness medicine elective, where we take medical students out into the wilderness for a month and teach them pre-hospital care and wilderness medicine. And I also used to teach wilderness medicine courses for NOLS. So that's some of my background as to why maybe, in addition to being an emergency medicine doc, I get to talk about heat emergencies. So we'll go to the next. So this is the title that Eric gave me: Heat Emergencies, Recognition, Management, and Operational Considerations. When I talk to the residents, give the residents this talk, the title is actually Hot in Here, thrown back to the 2002 Nelly song, if you guys are familiar with it. And one of the reasons I titled this talk Hot in Here is because anyone that knows me well, like Matt Scholl, knows my nickname is Nelly. So the title of this talk is Hot in Here, with a throwback to Nelly from 2002. Thanks for the smiles. So the outline for today's talk, we're going to talk about some of the background of heat illness. We'll talk about some basic pathophysiology. We'll talk about the spectrum of heat illness, a lot of what we respond to both in the pre-hospital setting as well as in the emergency department is part of the entire spectrum. So we'll talk about heat cramps, heat syncope, heat exhaustion, and then heat stroke, which is the true emergency. And then we'll talk about treatment, which is cooling. So heat illness, what is it? So heat illness is a group of diseases that just involves the body's ability to cope or really not cope with the heat in the environment. And today I'm talking about environmental heat illness. Clearly, there are other forms of heat illnesses as well. There's febrile illnesses, there's neuroleptic malignant syndrome, malignant hyperthermia. Not talking about that today, even though they're interesting. We are talking about environmental heat illness. And so, yeah, environmental heat illness is when the heat gain that our body gets through various mechanisms overwhelms the body's ability of heat loss. And what happens is our core body temperature, right? It rises and rises. And when it gets to a certain degree, systems in our bodies start to break down and heat illness follows. So heat illness, there's a huge burden of disease of heat illness. So in the United States, more people die each year from heat waves than from all other weather-related exposures combined. And I was looking it up last night, but the latest estimates are that more than 1,000 people die each year in the United States from heat illness. And this is likely an underestimate. And a huge burden of disease is among the elderly. So those older than 65 account for almost 50% of cases of heat illness. And as we'll talk about today, the morbidity and mortality is increased when therapy is delayed. Without a doubt, the burden of heat illness is increasing. We all know that the global temperatures are rising. We're having more and more hot days, more and more heat waves, more and more humidity. We also, in the state of Maine, have a growing elderly population, and these folks are very much at risk for heat illness. And then also we have more people choosing to engage in outdoor activities, extreme sporting events, competitions, and trainings that put them at risk for heat illness. So for all these reasons, the burden of heat illness is increasing, and the numbers are increasing each year. Despite this, us as humans have an amazing ability to thermoregulate. The person in the front here is my friend Liza Howard. She is an ultramarathoner. This is a picture of her running the Badwater 135. So It is a 135-mile race through Death Valley, California in July. That is crazy. So she runs 135 miles, temps in 100, 110 degrees, and somehow her body is able to thermoregulate and get through this. So we actually have an amazing ability to thermoregulate, and we can keep our body in that kind of sweet spot of 97.7 to 99.5 degrees Fahrenheit. We have natural autonomic mechanisms that balance heat loss and heat gain, and then we have an array of behavioral adaptations as well. And so what our body wants to do is our bodies are constantly making heat. We have this constant metabolic heat production through our metabolism muscles, and that has to be balanced with what we're receiving from and giving out to the environment. And so we have to have this kind of balanced equation to keep our core body temperature regulated. And so we're constantly transferring heat with the environment, and I'll talk about these mechanisms in a bit, but we have conductive heat exchange, convective heat exchange, radiation, evaporation. And if this equation becomes unbalanced, if we either gain or lose too much heat, we either develop hyperthermia or hypothermia. So bear with me for some light statistics. When I used to teach wilderness medicine courses for the National Outdoor Leadership School, we would talk a lot about these mechanisms of heat exchange. And so if you go back to your grade school physics, right, we have conduction, convection, radiation, and evaporation. And I do think it's important to have a basic understanding of these to not only understand how we get in trouble with heat illness, but also how we can manage and treat heat illness. So if we look at this diagram here, we can talk about the different things. So conduction. Conduction is when you're physically touching, you have direct physical contact with an object, and there's heat transfer. So in this picture here, it's the picture of the hand holding the handle of the hot pot, right? That's conduction. You're touching the hot handle, the conduction is going into your hand. Another way that we would get conductive heat loss is if we are, say, like lying on a cold rock, right? Where the heat from our body is transferring down to that cold rock. A really effective form of conduction is when our bodies are submerged in cold water. This is a really, really effective way of conductive heat transfer. And in fact, our body will lose heat 25 times faster to cold water than it will to cold air of the same temperature. So conduction is super important when we talk about how we can dissipate heat from a body. Convection is another way that heat is transferred. So convection in this diagram is the bubbling, moving air water molecules there in the pot. So convection is transfer of heat through the movement of air or water molecules around the body. So this is why we lose heat when there's a fan blowing air past us, or why we choose to wear loose clothing on a hot day, so we can get convective heat loss. And under kind of normal, neutral, not extreme conditions, convection is a lot of the way that we're losing heat throughout the day. Radiation. So that's heat transfer by electromagnetic waves through space. So that's in this diagram is the radiation coming off the fire. So any warm body is losing radiation heat to the environment. So as humans at 98 degrees, we're often giving out a lot of radiant heat to the environment. But when we're in a really hot environment, like a really hot sunny day, we may be gaining heat through radiation. And then the last method of heat transfer is through evaporation. So we all know evaporation is when liquid is converted to a gas, and this gives off a large amount of heat. And this is why sweating is a super effective way to give off heat. So when we evaporate just 100 cc's of fluid or water off our skin, we can lower our body temperature by a full degree centigrade. So this is the most effective way for us to get rid of heat in high ambient temperatures is with evaporation and sweating, but we lose this ability when the conditions become very humid. So when humidity goes above 75 degrees, we lose our ability to have effective evaporation, which is why hot and humid climates can be so dangerous. So again, we talked about the methods of heat exchange, just back to high school physics. So we talked about conduction, which is direct contact. Remember that when we talk about ways to treat heat illness, like in ice water tubs. We talked about convection, which is when water or air molecules move past our body. That's a good way to lose heat through things like fans. We talked about radiation, which is electromagnetic waves. Again, we're in a heat illness talk. That's a lot of the heat we're gaining from the sun. And then we talked about evaporation, which is sweating. And remember, our ability to sweat and evaporate off heat, we lose that ability when humidity gets above 75 degrees. 75%. And as I mentioned, like that picture of my friend Liza running through Death Valley, our body has an amazing ability to thermoregulate. So inside our brain, our hypothalamus is really the body's thermostat. And so it knows when it's cold out, we got to start shivering. We got to start getting our muscles moving to increase our metabolic heat production. It also knows that at low ambient temperatures, we should vasoconstrict in the periphery. So we pull that blood to our core vital organs. In warm temperatures, though, our body knows that it's time to vasodilate, that it's time to send blood to the periphery. Let's increase the blood flow out there. Let's start sweating. Let's cool down. We also clearly have behavioral responses to heat stress. So we know that if it's hot or if it's cold, or cold or hot, we're going to add clothes or remove clothing. We'll get wet or dry. We'll move into the sun or the shade. We know to start moving our muscles, like doing jumping jacks, or to lay out on a cold rock. So we have lots of behavioral adaptations to heat stress as well. There are some high-risk groups for heat illness as we start talking about that. And one of the reasons these groups are high risk is not only do they not have the right physiology, but they also sometimes don't have the right agency or the ability to alter their environment. So infants and children are at high risk for heat illness that we're going to talk about. Some of that is physiologic. So kids don't have are not as efficient at sweating yet. They also have high metabolic rates. So they're not only producing more heat, but they can't sweat it off as easily. And then a huge risk factor for kids is they have an inability to care for themselves and modify their environment, right? And we've all heard the stories or perhaps seen the cases of kids locked in hot cars, right? They can't modify that environment. They can't get out. So they're at higher risk for heat illness. Another group similarly is the elderly that's at risk for heat illness. Their physiology puts them at risk. They have limited cardiovascular reserve, so it's harder for them to peripherally vasodilate. It's harder for them to increase their cardiac output when they need to deal with heat. They also sweat less as we get older. And then sometimes they're on medications that might affect their ability to sweat and their volume status. And then sometimes they have, again, inability to care for themselves. Maybe they can't get out of that hot environment. Maybe they can't modify that environment or get the air conditioner fixed. And then the final group that we worry about with heat illness are young athletes and trainees. These are folks who are putting themselves into hot, humid conditions where they're exercising or training very hard. A lot of times there's a lack of acclimatization because they just don't know better. Maybe they're being pushed to do something by a coach or by someone above them. So they're also at risk for heat illness. So again, the pathophysiology of heat illness is when the heat that the body gains through the environment and through the kind of the metabolic demands of the body, when that heat gain overwhelms the body's ability to dissipate the heat. That's when our core temperature rises and heat illness ensues. And the number we really worry about is when that core temperature is above 40 degrees centigrade and 104 degrees Fahrenheit. And for me, that's easy to remember, 40, 104, 40, 104. When we get to that temperature, that's when we start worrying about the damage that's being done. You can have direct cytotoxic effects and inflammatory changes on the body. Cellular and metabolic mechanisms start breaking down. Many organs can be affected, multi-organ failure. And I don't want to go too into the weeds on this, but just to say that, again, many different systems in the body can be affected when the core temperature gets to be too hot. So when we think about the cardiovascular system, our body tries to compensate for all this heat stress. And one of the ways it does that is we increase our cardiac output, we dilate our blood vessels to try to get more blood to the periphery. So this can cause tachycardia, hypotension. And people that can't do that, like the elderly or people with cardiovascular disease or if we're dehydrated, they may become quite hypotensive, start hypoperfusing their organs. For the lungs, the pulmonary system, heat illness can cause pulmonary edema. It can cause ARDS or acute respiratory distress syndrome. This is one reason we need to be a little bit judicious about IV fluid resuscitation. For the gastrointestinal system, heat illness can cause, we can have vasoconstriction going to our GI system. So this can cause gut ischemia, it can cause vomiting, diarrhea, GI bleeds. Clearly, lots of electrolyte and fluid abnormalities happen with heat illness as well as dehydration. So your patients may have lactic acidosis. They may have either hypo or hypernatremia, hypo or hyperkalemia. If they're exerting themselves, they may develop rhabdomyolysis. And then the incidence of acute kidney injury is very high also with heat illness. And then finally, what we worry most about with heat illness and heat stroke is the central nervous system. So I'll talk about this in a little bit, but the hallmark of heat stroke, how we make the diagnosis of heat stroke, is a change in mental status or neurologic symptoms. So the patients we care for with heat stroke may be confused, they may be agitated, delirious, they may have hallucinations, they may be in coma. Seizures are super common. Up to 50% of cases of heat stroke can have seizure. There may be hard neurologic signs like cerebellar signs, ataxia, loss of muscle tone, hemiplegia. And when people have died of heat stroke and they do autopsies, their brains show edema, it shows hemorrhage, it shows that there's been degeneration of the neurons. So really, we worry a ton about the brain when it comes to heat stroke and heat illness. So I want to talk briefly about the spectrum of heat illness. So the kind of from the more benign would be heat cramps, heat syncope, heat exhaustion. And then what we worry about would be heat stroke, both classic heat stroke as well as exertional heat stroke. Heat cramps are super common. This is just when somebody in the setting of a hot environment, heat stress, develops cramps of their muscles. So this tends to occur in athletes who are competing for hours out in the hot sun. You know, if you were to check their labs, maybe they'd be a little bit hyponatremic or hypochloremic. Not that we need to check their labs. But these people just get cramping of their muscles in the setting of some mild electrolyte derangements, in the setting of heat and in the setting of mild dehydration. So if we care for someone with heat cramps on the sideline or in the community, really the treatment is for them to get out of the hot, to get into the shade, and to orally rehydrate. Water is good. Sports drinks are good. If you want to add some salts to their drinks, I know your guidelines talk about putting a quarter to a half a teaspoon of salt in a liter of water. Sounds terrible to drink, but it's giving them some sodium back. But really for heat cramps, it's just having them slow down, rest, rehydrate, get some salt back in their system, and then just talking to them about prevention, hydration, increasing their salt intake. So really not an emergency, but can be frightening to people and uncomfortable. Another thing we see with heat stress and heat illness is heat syncope. So this is when folks will have a syncopal event in the setting of a hot environment and heat stress. And so really this is because their body is trying to compensate for the heat, right? So they're having vasodilation, they're sending blood to the periphery so they can sweat. And a lot of times these people, while being very vasodilated, are just standing upright, maybe watching a soccer game or in a still position. And so they get venous pooling and they syncopize. Really, this is just an effective low volume. They may not even be that dehydrated. The way to manage this, right, is just to allow them to rest, allow them to lay down, hydrate them, cool them. The prevention is for them to stay hydrated out in the environment, to be moving their body a little bit, get that skeletal muscle pump to increase their venous return. But really heat syncope is just you passed out on a hot day, and really you need to stay hydrated and just be aware of your body. But not a medical emergency, but heat syncope is something that you will see and will have to manage. Okay, Heat exhaustion. This is probably the most common form of heat illness that you all see in the EMS environment, that I see in the emergency department. And this is just the strain that the body experiences from trying to maintain normothermia and heat stress. And oftentimes when we talk about heat exhaustion, the person is to some degree dehydrated as well. They've been sweating a lot. They have some unreplaced losses. And in the setting of heat exhaustion, as our body is trying to maintain this normothermia, the symptoms they're going to have are going to be headache, dizziness, fatigue, nausea, vomiting, diarrhea, anxiety, thirst, heat cramps. Maybe they'll have heat syncope as well. When you check their vital signs, because they're trying to compensate for the heat, they may be tachycardic, they may be a bit hypotensive, either because of the vasodilation or they're mildly dehydrated, tachypnic, diaphoretic, they may have goosebumps. But the key thing with heat exhaustion is even their body is really fighting to maintain their core body temperature in a normal range. So their body's actually doing it. Their body's stressed from how hard it's working, but they are not truly hyperthermic. That is the key thing. Heat exhaustion is their body's exhausted from trying to maintain this normothermia. But if you get a rectal temperature on them, it's going to be less than 40 degrees centigrade or 104 degrees Fahrenheit. There are two types of heat exhaustion. There's exertional heat exhaustion and classic heat exhaustion. Exertional heat exhaustion is common in athletic events, right? Athletes, trainees, military, fire, police out there for many hours, exerting themselves. Exertional heat exhaustion tends to develop over minutes to hours. And then classic heat exhaustion is more of an illness of the elderly, the young, the sick. It develops over more like days. It's chronic heat stress, chronic dehydration, and these patients may have some frank dehydration and electrolyte imbalances. This is from your Maine EMS guidelines about heat exhaustion and how to treat it. I'm just going to zoom in. I think these are great. So, with heat exhaustion, you want to, first of all, kind of move the patient out of that heat stress. So protect them from the heat challenge, have them stop exercising, put them at rest in a shady place. Using evaporative techniques and to help with them start to sweat and cool down is great. So loosen up restrictive clothing. You can spritz them with water, get a fan going, and oral hydration, maybe with a little bit of salt, is a great way to rehydrate them. If clinically the person appears dehydrated, it could be reasonable to get IV access and give them a bolus of fluid. But oftentimes this is not needed. And oftentimes for heat exhaustion, if we can just cool the person, get the person into a cool environment and start orally rehydrating them, that's great. So cool them down with cold water, fan them, rehydrate them with water and electrolytes, grab them a sports drink, put a bit of salt in their water. As far as whether or not these people need to come to the emergency department, I would say that they often do, but the truth is that sometimes these people can just be managed at home or on the sidelines. Reasons to transport clearly would be if they're persistently abnormal vital signs, if they're dehydrated and they need IV fluids, or they have really significant symptoms, then, obviously please transport them for heat exhaustion. When heat exhaustion, great time, as you all know, just to go back and talk about prevention, talk to the coaches, talk to the lieutenants about hydration, being aware of the heat and humidity, the heat index, and recognizing the symptoms of heat illness early. Before we go into heat stroke, does anyone have any questions or comments so far about about heat illness, the spectrum, so heat cramps, heat syncope, heat exhaustion, or anything to add from Matt, Eric, Joe? Okay, I'm looking at you, Matt. Great. Okay.
Yeah,
so
I
heat
think we're
stroke.
spot on so far.
Okay, thanks, Joe. Okay, so heat stroke. So this is the one we worry about. So heat stroke is a true medical emergency and is fatal if not recognized and treated promptly. And heat stroke is defined by true hyperthermia. And so again, in my simple mind, I remember a core temperature of 40 centigrade or 104 Fahrenheit, 40 and 104. And there are some CNS changes, whether that's altered mental status or neurologic dysfunction. Okay. So again, heat stroke, let's repeat that, is a true medical emergency, and it's defined as a core temp of greater than 40 degrees centigrade plus CNS dysfunction or altered mental status. What heat stroke happens because, again, the heat gain from the environment outstrips our body's ability to dissipate the heat. And so all these normal, amazing thermoregulatory mechanisms we have break down. The patient starts becoming tachycardic, tachypnic, hypotensive, and altered, and their core temperature rises. Heat stroke is divided into two main subtypes. There's classic heat stroke and exertional heat stroke. Classic heat stroke tends to occur over days. This is a disease of the elderly, the very young, alcoholics are at risk, people that are chronically ill are at risk. There's lots of social determinants of health that play into classic heat stroke. So poverty, lack of air conditioning, immobility, being in confined spaces like cars, boiler rooms, basements. And when these patients finally present, because this has happened over a course of days, they may have some pretty significant, or they will have some significant dehydration, electrolyte abnormalities. And heat strokes are super common during heat waves, and I know I feel like in Portland we're starting to do a good job of setting up cooling shelters when we need to. But heat waves, a heat wave is defined as 3 consecutive days of more than 90 degrees Fahrenheit. And as we all know, heat waves are becoming more and more intense and prolonged across the world. So we were having more hot summer days, higher maximum temperatures, fewer days where it cools down at night, and just higher heat and humidity indexes. So for all these reasons, classic heat stroke is becoming more and more frequent. And we need to be really aware, especially of these vulnerable populations like the elderly, the infirm, who may not have access to air conditioning and other ways to stay cool. So that's classic heat stroke. And then the other form of heat stroke is exertional heat stroke. So this tends to be in the young and the healthy, and those that are doing exertion in warm environments. Very common in sporting events and in performance testing. So football tryouts, military recruits, police and fire training. I know we'll see cases of exertional heat stroke at the Beach to Beacon every August. Really the sporting event doesn't even have to be that long, but if it's hot and it's humid and the people are exerting themselves and aren't acclimatized, there is a risk. With exertional heat stroke, this can happen really quickly. So it can occur in minutes to hours, again, when people's heat dissipation is limited. So think about hot, humid conditions where people aren't able to sweat and lose heat through evaporative cooling. Think about inappropriate impermeable clothes, so they're not able to get some of that convective heat loss. And in the right or maybe the wrong conditions, the body temperature can rise up to 0.5 degree centigrade per minute, so really quickly. And exertional heat stroke is the second most common cause of sudden death in athletes. The most common cause would be cardiovascular conditions like hypertrophic cardiomyopathy and arrhythmias. But exertional heat stroke has a huge burden of disease among athletes. One of the most famous cases of heat stroke that is still talked about in the literature was back in 2001 with the Minnesota Vikings. So this is Corey Stringer. He died when he was 27 years old, and he died during a Vikings football practice. So he was an offensive lineman, and the way they described this day back in 2001 was it was temps in the low 90s, stifling humidity, and during practice, Corey vomited 3 times and then lost consciousness. When he arrived to the hospital, his core temperature was 100.8 degrees Fahrenheit or 42.7 degrees centigrade. It looks like he was, managed appropriately, cooled in an ice bath, packed in ice, transferred to the ICU. But unfortunately, his heat stroke had gone too far. And so he had developed rhabdomyolysis, renal failure. He required hemodialysis. He eventually had multi-organ failure and died. So that was Corey Stringer back in 2001 from heat stroke. And, I guess the only silver lining from this is that this brought about some really major changes regarding heat stroke prevention throughout the NFL and throughout professional sports. And now, at least in the NFL, teams train in light colors. There has to be water, shade, and fans available. And there's team doctors and clinicians at all practices. So there were some changes made because of the Corey Stringer event in 2001. So just to hammer it home, we're going to see a lot of heat exhaustion, and we will see some heat stroke as well. But there is a difference, and so that the boundary between heat exhaustion and heat stroke is really that core temperature. So the number that I remember in my mind is 40 degrees centigrade and 104 degrees Fahrenheit. Granted, this is somewhat arbitrary. If you're, if you're 39.5 degrees centigrade but have altered mental status, I'm still going to say you have heat stroke. But it's really that these people have a very high core temperature and they have CNS dysfunction and mental status changes. And then again, we talked about classic versus exertional heat stroke. Both end up at the same point. So both end up with a high core temperature and with CNS dysfunction. Both can be tachycardic, tachypnic, hypotensive. Classic heat stroke tends to be a disease of the elderly, the children, the infirm. It tends to happen over days, and we really worry about heat waves. Whereas exertional heat stroke tends to be more of the young athletes, military laborers. It's more rapid and episodic. Some people try to push like what the skin looks like to differentiate the two. The classic heat stroke, maybe your skin is more dry, you're flushed and pale, versus exertional heat stroke is profuse sweating. Sure, I'm not sure that is that clinically important. It's more just like who the patient is, what the time course was. But again, at the end, they get to the same place. Their body temperature is too high and they have CNS dysfunction. So this is from Maine EMS, the hyperthermia heat stroke guidelines. And so zooming in, and I'm going to break it down a little bit more, talking about the treatment of heat stroke. So the treatment of heat stroke is radical cooling. And I don't know, I'm going to blame Matt Scholl for this. I've never heard the term radical cooling before, but I love it. It's like rapid, aggressive cooling. But yes, rapid cooling is the mainstay of treatment for heat stroke. And we're going to kind of march through kind of ways to do this now. But really we know that morbidity and mortality is directly related to for how long these people are hyperthermic. So you want to get them as cool as quickly as possible. And in your guidelines, it talks about ice water tubs, which we'll talk about. It talks about the TACO method, the TARP assisted cooling with oscillation. We'll talk about that. And then it does talk about at the advanced DMT and paramedic level, getting an IV, getting them on a cardiac monitor and giving them some fluids. Okay, so rapid or radical cooling is the mainstay of heat stroke. Again, because the longer we're hot, the worse our outcomes are. So we want to get that core temperature down quickly, ideally within 30 minutes. And our goal is to get them below 102 degrees Fahrenheit or 38.8, okay? So you can't go too fast, but you can go too low. So we don't want to make these people hypothermic, but you can get them down as quickly as you're able. And this is one I was talking to Matt and Eric before this call. I think this is a great example of where EMS can really be the lifesavers, as you are with so many things, but you want to kind of start the cooling process immediately. So this idea of starting cooling, effective cooling immediately, and then transporting as opposed to transporting and doing the cooling in the ED. So when we're managing heat stroke, we want to get off any restrictive clothing, ideally get an IV in, check the point of care glucose, get a core temperature probe in them, rectal probe, be judicious with IV fluids, and then start cooling. And the best ways to cool are with conductive cooling. So remember, I talked about, when we're talking about heat transfer to the environment, that heat transfer into cold water is 25 times more effective than heat transfer into cold air. So we want to get them in a nice water bath. We want to do the TACO method. We want to do a body bag, maybe ice slush with towels and sheets. This is the best way to cool people. You can also throw on some other adjuncts like with some evaporative and convective cooling techniques like fans and spraying with water, but really the conductive cooling, the ice water bath, the cold water is the way to go. So these are just examples of ice water baths. The one on the right with the blue square over her eyes was a patient I had last year. I was doing an ice water bath out in the ambulance bay at Maine Med. I know if any of you have worked the Beach to Beacon, you have their big black tubs are kind of ubiquitous. So ice water baths are awesome. So throw a ton of ice in there, fill it up with some water, get the patient up to their neck. This is a great way to cool people down. It's very effective. It's easily available. you can start dropping people's body temperature by about 0.2 degrees centigrade a minute, which means that within 15 minutes, you're getting them down 3 degrees centigrade, which is awesome. I think the challenge with an ice water bath is availability. If you're not carrying this on your rig, where are you going to get it? Transporting somebody is hard in an ice water bath, clearly. And then monitoring can be hard as well. So especially with classic heat stroke with elderly folks, it can be hard to get people in and out of an ice bath. Maybe you don't think that they're medically stable enough to be sitting in a big thing of water. But for the right patient, the ice bath is the way to go. And it's great for sporting events and sidelines. The TACO method is in your guidelines. TACO is TARP assisted cooling with oscillation. I tried apparently this is fun because I looked for pictures of this, and every picture everyone's smiling during it. So I don't think it's really fun, but I think it's fun to put your colleague in a tarp and swish them around. But basically you take one of those big blue tarps, you lay your patient down, you cover them with ice and cold water, and you pick up the tarp so they're in kind of a hammock of ice and cold water. And then you start oscillating them back and forth. So the TACO method, tarp assisted cooling with oscillation. If you have these things, if you're in a wilderness setting or a campground setting, you're bound to have these things. So again, a tarp, some ice, water, put the patient in, the rescuers pull up the sides and start oscillating them around. That's the TACO method. Probably more practical for EMS and what we're starting to do in the emergency department as well is the idea of using a body bag and filling it with ice. So again, take a body bag, get as much ice as you can, fill the body bag with ice and water, have the patient inside. And this is a great way to start cooling at the scene, but then also you can transport the patient in this, which is wonderful. So as opposed to the water bath with ice water or that TACO method where you have to have people oscillating back and forth, this body bag with ice is great because not only is it effective, but you can also start transporting the patient. With all three of these methods, you want to keep an eye on their temperature. So ideally, you'd have a continuous temperature probe, like a rectal probe, but doing intermittent checks is fine as well. So taking the patient out every 15 minutes to check their temperature. But I think this body bag with ice is a great way to go. And then another thing I've done in the emergency department and something that you could do in the back of the ambulance is the idea of, if the patient's on a stretcher, covering them with wet towels or with wet sheets. And then again, dumping basically like an ice slushy on them, cold water, ice, just getting it over them while they also have the wet sheets and towels on them. That gets some conductive heat loss. You could also turn the air conditioning up, get fans going, but however you can just to start cooling the person. Because again, our goal is to get them down in the first 30 minutes. There are other techniques that are described. You can spray with water and get fans going, ice packs to the axilla and the neck, cold IV fluid. We used to talk about gastrical lavage. These things, to be honest, they're just not as effective. And so whenever you can do the conductive cooling methods, like with an ice water bath or the body bag, that's the way to go. And there are not big randomized controlled trials to say that, but all of the case reports and small clinical trials we have seem to point towards cold water immersion. The best study I could find was from 2007 in Critical Care Medicine, which is a review. And when they reviewed all of these 19 clinical trials, again, they pointed towards cold water immersion as the most effective for exertional heat stroke. They didn't come down quite as definitively for classic heat stroke, but I think as long as it's safe for that patient, I think getting them in a cold water bath or in a body bag is the way to go. And again, you can start reducing their temperature by up to 0.2 degrees centigrade a minute. So you're getting them down by 3 degrees in 15 minutes, which is great. Again, there's no risk of going too fast. There's just a risk of overshooting. And patients that receive prompt care have the strongest likelihood of recovering. Our goal with cooling people with our our rapid radical cooling is to get that core temperature to less than 38.8 or 102 degrees Fahrenheit. That's what's in your guidelines. And your guidelines also say, the Maine EMS guidelines say to stop rapid cooling once shivering begins. When these patients come to the emergency department, we basically keep doing the same thing that you have started. So when a patient comes into the ED with hyperthermia, with heat stroke, we're doing our ABCs, we're getting IV access, we're putting them on the monitor, we're checking a blood sugar just like you've done. We're getting a core temperature, probing them, ideally continuous, so rectal, esophageal, or Foley. And then again, we're trying to cool them to get them below this 38.8 or 102 degrees Fahrenheit, with a goal of getting that within 30 to 60 minutes. Because heat stroke can have effects on so many different organ systems, we are going to be checking labs. We'll check a CBC and CMP. We'll check coags and a lactate, maybe a CK for rhabdomyolysis, chest X-ray for pulmonary edema. If they're altered, we may get a head CT. And then if the patient does start shivering in the emergency department, and we have not yet gotten down to below 102 degrees Fahrenheit, we'll give some IV benzodiazepines to suppress the shivering so we can continue the cooling process. This hot off the presses, we at Maine Med, we're developing an environmental heat-related injuries pathway guideline, which is really just what I talked about. So, this is zooming in, just talks about how heat stroke is defined by that core temp of more than 40 degrees centigrade and the alteration in mental status or CNS changes. And our treatments are just what we talked about. So I have to put my glasses on because this is so small on my screen. But you can see that box A is the ice water immersion for treatment. Box B is the body bag. Maybe I just messed them up because it's actually hard for me to see. But you got ice water immersion, body bag, and then doing cold towels and sheets with an ice slushy on top of them. So those are our preferred treatment in the emergency department, just like you'd be doing out in a pre-hospital setting. And then as far as disposition from the emergency department, if someone comes in with heat stroke, if we can get them cooled and get them back to their mental status baseline, and they have no significant medical abnormalities on their workup, and they're able to ambulate and tolerate oral fluids, we're going to be discharging them. If people have significant organ damage from heat stroke, or they have evidence of pulmonary edema, or they're unable to walk or tolerate POs, we may end up admitting them. And then clearly some folks need to be admitted to the ICU if they're intubated, if they have hemodynamic instability, or if they're in organ failure. So just to summarize what we've talked about, so more people die of heat illness than from any other environmental cause. So a big burden of disease across our country and across the world. Remember that thermoregulation, our body does an amazing job of trying to balance the metabolic heat we produce as well as the environmental heat transfer, but that this ability to thermoregulate is affected by the environment in which we live, our age, and our comorbidities. Remember that heat illness is a spectrum of disease. We talked about heat cramps, heat syncope, heat exhaustion, and then heat stroke. And heat stroke is those CNS changes plus a core temp greater than 40. There's both classic, which is over days, tends to affect the elderly and the infirm. And then there's exertional, which happens over minutes to hours and tends to affect athletes and trainees. And then the key to all of this with heat stroke is to cool them and to do as quickly as possible. The preferred modalities are ones that are going to use conductive heat transfer. So ice water baths, that taco method with the oscillation, body bags, the ice slush through the sheets and towels. And with that, I'll end with a final slide of my daughter sleeping on an iceberg in front of our house this spring, which seems like another great way to cool down on a hot day. And with that, I'll take any questions, or I'd love to hear comments from others.
Sarah, there was a couple questions in the chat. First one was, how long does core cooling continue after the patient is removed from cold water bath?
Oh, great question. I don't know the answer to that. I think you're going to continue to monitor them until they get to a steady state. But as soon as you're out of that, as soon as you're out of that ice water bath, you're not having that conductive heat loss anymore. So you're not doing much more aggressive cooling. I don't have a great answer to that. Does anybody else have a good one? Yeah. I would assume you're going to keep cooling a little bit because you now have a wet body and maybe you're bringing them to a space where you have some fans going, the air conditioning's going. But I think that with that, in your guidelines and our guidelines, you're bringing them down to 102 degrees Fahrenheit with the kind of that rapid cooling. What was the word that you guys used in your guidelines, Matt?
Radical.
Radical. You're radically cooling them until 102, and then from 102 till normothermia is more just their body's wet. There's some fans going. You're doing more of the convective and evaporative cooling. So, hope that answers the question.
I believe so. Can you give some other examples of central nervous system signs besides AMS that you commonly see with heat stroke?
Yeah. So, I don't know why, but for whatever reason, the cerebellum tends to be affected. So you'll see people will come in with ataxia, difficulty sitting upright, difficulty walking. They do describe people coming in with hemiplegia as if they've had a stroke, and then seizure.
Let's see. Thank you. Are we only counting body temp from a rectal temp, or can regular thermometer be used as well?
Yeah, I think the core temperature would be best. So I think rectal, Foley, or esophageal would be the top three. After that, would be oral. I think it's hard to count on a forehead temp or a tympanic temp because those sensors are also just affected by the environment. And as this person goes from being very hot to starting to cool down, they can have changes in peripheral vasodilation and constriction. So as core as possible would be best. So again, ideal would be rectal, Foley, or esophageal. Oral would be a pretty good second place. But I would not rely on tympanic or forehead.
Great. What happens when when we overcool beyond the shivering stage?
Yeah, I mean, I think you're just at risk. One thing is you start kind of once someone starts shivering, you basically their body is fighting your mechanism. So they're shivering, they're trying to produce heat, and so you're just getting into a push-pull that doesn't make much sense. The main risk is just you're going to make them too cold and create hypothermia. I think, to be honest, that's more in a hospital setting or an EMS setting. It's a bit more of a theoretical risk if you're just not monitoring the patient. It would be hard to, I can't imagine just leaving someone in a cold water bath for hours and making them hypothermic to a place where it was clinically relevant. But again, I think the risk is that when they start shivering, they may even they're going to start fighting all your mechanisms to cool them down. And then if you make them hypothermic, that's going to be uncomfortable. And if you go too far, clearly there can be untoward clinical sequelae of that as well.
Thank you very much. Let's see. How long do you do radical cooling on scene given a 20 or 40-minute drive time to a hospital?
Yeah, that's what I was talking to Matt and Eric about before the call. I think I would say it would depend on the resources you have. I think the body bag, being able to put someone in a body bag, fill it with ice and cold water, get that set up, and then start driving is such a great solution for a pre-hospital context, because not only are you doing the cooling, but you're also moving towards more definitive care. On the flip side, if you're in a place that if you don't have a body bag, but you have a bathtub right there, and you chose to stay and cool for 30 minutes because you have a really great bathtub and an ice machine right next door, I don't think anyone could fault you on really managing the patient in the field. So I think it depends on the context, balancing cooling with moving towards the hospital. But the most important thing is just to start the cooling process immediately, and to start it as well as you can. Does Matt or Joe or Eric, do you have any other comments on that though?
No, I think that's a great general idea, Sarah. And the other option for the person who left the question is there can be significant nuances that go on in some of these cases. And so contacting online medical control at the time of care of the patient might be helpful as well.
And like at Beach to Beacon, for instance, maybe Joe could talk to this, but I mean, a lot of the definitive treatment just happens at Beach to Beacon. So some patients, if we can get them back down to normothermia, I don't know, Joe, are you transporting all heat stroke from Beach to Beacon?
No, actually, the transports are an absolute minority. I think this past year we cooled, I don't know, 20-ish people maybe, and I think we had 2 transports. One was heat stroke and one was unrelated. So no, it's an absolute minority, but that's because we have a pretty structured protocol in place of how we're managing those folks. So I think in that setting, more likely to discharge. I think from the true 911 EMS setting, more likely to still transport and bring them in.
Yeah. And if you, I mean, I think I used the word ice in all of my examples. Clearly, you may not always have access to ice. So that's when you may be going down the line of other ways to do convective and evaporative heat loss. So that's when you're, putting sheets on them, getting cold water and using a fan or turning the air conditioning up really high in the rig. Like if you don't have ice and great ways to cool at the scene, maybe that's another reason to start transporting.
Yeah. To Sarah's points though earlier about all the different ways that heat loss happens. Even if you don't have ice, if you have access to water, body bag and water is going to be more effective heat loss than just sitting on the stretcher by itself. So it's a matter of doing best with what you have. I know last summer there was a crew that briefly stopped at a convenience store that they were passing on the way from a scene to the hospital and grabbed a couple bags of ice. So kind of make do with what you have. And yeah, like Sarah said, online medical consultation is always your friend. So if you ever need to brainstorm and say, hey, I'm X minutes or X miles away with this situation, what do we do? And we can work together to brainstorm.
Yeah.
And I think, let's see. Seems like a fine line. Other than core temp, what separates heat exhaustion from heat stroke?
Yeah, it's when you look at the literature, they really talk about having CNS effects in heat stroke. So again, the confusion, the delirium, maybe hard neurologic symptoms. That defines it. That being said, and again, sorry, Joe, I'm looking at you on Teams, but I bet that at Beach to Beacon, when the runner comes and is just kind of woozy, but you get their core temperature and it's 105 degrees, you're going to start cooling them. You're not going to wait for them to become agitated, delirious to start cooling them aggressively. But the medical definition of heat stroke is that high core temperature and CNS changes. Where again, heat exhaustion is just like you feel really lousy because it's hot outside and you're dehydrated. But your core temp is not above 40, and you're not altered. You don't have any CNS effects.
Yeah, that's the experience. I mean, between Beach to Beacon or at Maine Marathon, a lot of it's slightly different, right? Because it's self-selecting in terms of people either present themselves to the med tent or it's the volunteers at the finish line who are walking or watching for the kind of wobbly, stumbly folks. And so that alone, that's that sort of ataxia piece, or the folks that are looking confused when they finish. So it's either people pulling them from the crowd or they're self-presenting. But some of them just come in more truly heat exhaustion without altered mental status. But yeah, if their core temp's over 104, they do get cooled regardless.
And then there's a lot of heat exhaustion, right? That doesn't have like your body is still thermoregulating. You still have a temp of 38, 39 degrees, but yeah, you're nauseated, you're vomiting, you feel weak. Those people also, need to be in a cool environment. Maybe they need to be fanned. They need some oral hydration, maybe IV hydration. They may not necessarily have to put into an ice bath if their core temp is not greater than 40.
Yep.
Matt, I think this one's more for you. Rectal probes are permissible equipment for EMS.
Yeah, as Sarah mentioned, most of the other means of checking temperatures are failable, especially like the skin temperature probes. Both for hyperthermia and hypothermia, core temperatures are preferred. Many of the monitors will have an option for a core temperature probe that can be purchased, although some folks have used lower cost alternatives, including regular indoor-outdoor thermometers that have that long tail on them. And the long tail can be inserted into the core of a patient, and we can check temperatures that way. Hope that answers the question.
I believe so. And besides the core benefit of rapidly lowering temperature, are there any risks or other body systems when a severely hyperthermic patient is immersed quickly into cold water?
The only risks that I am aware of is just in a critically ill patient, it can be hard to manage them and resuscitate them and monitor them. So clearly, if someone's critically ill and if they're critically ill and hypoxic and not maintaining their airway, like I'm not going to put them in a water bath. I'm going to intubate them or put them on positive pressure ventilation and figure out other ways to cool them down without putting them in a water bath. Same thing. I think it just depends on what else is happening for this critically ill patient, whether or not they're well enough to get into a water bath. In my limited experience, again, I would look towards others to get someone into a water bath. Like they need to be able to, you either need to pick them up and put them in and take them out, or they need to be able to step in on their own. That can be challenging, which again, may push you, critical illness and their mobility may push you more towards, hey, let's just keep them on the stretcher, put them in the body bag and fill it with ice and water. That may be a much easier way to manage a critically ill patient than having them in a huge tub of water.
Excellent. I think that covers our questions from the chat. It looks like, Matt, you covered the ones in the Q&A.
Great.
All right. Sarah, thank you for doing this today, and everyone, thank you for coming.
Yeah. And if folks, we are, as I mentioned, we're currently writing up guidelines for the Maine Health Emergency Departments as far as management of hyperthermia and heat-related illness. So if folks have suggestions, maybe based on this talk for things that we should change, I'm one of the authors of those guidelines, please don't hesitate to reach out to me. But I really appreciate the opportunity to talk to you all, and thanks for all you do. And stay cool out there on these hot days. Go lay on a nice bird.
Thank you, Sarah. Appreciate your time.
Yeah, take
Thank
care.
you, Sarah. All right.
Thanks, Sarah.